thank you for joining the Center for Learning Health System Sciences for our special edition impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. The public slide deck will also be made available on our website under the Education tab, and I will share that link in the chat. Following the presentation, we invite you to raise your hand in person or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, for upcoming LHS events, our monthly seminar will return on Tuesday, November 1st with Dr. David Dorr of Oregon Health and Sciences University. He will present data-driven learning health systems using patient-facing digital health applications. And with that, I will turn it over to Dr. Jerica Burge to introduce our speaker.
I think
they're both.
If we can mute one of them, I think we're getting some feedback. Does that work? Okay.
Yeah.
Thanks, everyone. Jerica Burge, Professor and Vice Chair for Research in the Department of Family Medicine and Community Health. And my connection to class is that I currently direct the Practice-Based Research Network here at the University of Minnesota in the class, as well as Department of Family Medicine and Community Health. So I'm honored to introduce Linda Zittleman, who joins us from the University of Colorado School of Medicine and is the co-director of the High Plains Research Network. And I've admired her work from afar as I've seen her present or looked at her publications in journals about their work and how we've tried to model our own practice-based research network after them. Linda is a public health and primary care researcher working to improve health in partnership with primary care clinics, public health organizations, community-based organizations, and local community members. She has expertise in both practice-based research and community-based participatory research, and in community-engaged research methods in education, with a particular focus on rural and underserved communities. So for the last 17 years, Linda has held various roles in supporting and leading the High Plains Research Network. And today we are glad and excited to really welcome her and hear some of her notes from the field. So welcome, Linda.
Thank you. Wonderful. Thank you, everyone. Again, I'm Linda Zittleman, and it is just a joy to be here today, being here in person, being in Minnesota, and learning more about what all of you have going on. There's so much already going on. It's my pleasure to be here to talk a little bit about what this practice-based research work has looked like in rural eastern Colorado. Let's see here. There we go. I'm going to get, this is, just let me think for a second. I think this is my first in-person presentation in 2.5 years. So a little rusty with some of the technicalities. But I'm not sure if everyone who is listening knows kind of the concept of practice-based research. Okay. I was originally looking for some inspiring quote or something that we could start with. But for those of you who are familiar with this, this is actually very eloquent. And I thought, let's start with the car white boxes. Has anybody here seen this before? Probably some of you have. So the concept of practice-based research, what is that? This was a study actually done many decades ago and replicated recently. Carr White was a clinician researcher, a pioneer in primary care research, who said, you know, if we had a population of 1,000 people, how many of those are actually participating in helping inform the work that's being done, the research that's being done? And if you look down here, there's this teeny box of one person who, after identifying an issue, seeing a physician, maybe being referred, ends up in a university medical center such as this. Most of traditional health research is done in that setting, and that's fantastic. It's great. We learn a lot. There are a lot of innovations generated there. But what do we do with those? How does that look in the real world setting? And that's where practice-based research comes in. We aim to take this out to at least this box of at least 250, where more people are seeing in primary care settings. Not all practice-based research is primary care, but a lot of it is. And it's where most people get most of their care most of the time. You've probably heard that one before. And in some networks, you can even expand that out to even a more broad community. So that's really the genius of practice-based research. I'm just going to set this over here. So what about the High Plains Research Network? What's its story? Well, it was founded in 1997, so it's been around. We're in our 25th year. I joined in 2005, and it's based at the University of Colorado in the Department of Family Medicine. This is a beautiful picture of campus. Can all of you see this? Okay, am I in your way? Okay. We have campus here. It's Anschutz Medical Campus, and facing west, the mountains, beautiful sunset. That's what most people think of, I suspect, when you hear Colorado. But all of the work that High Plains does is actually in the opposite direction, in eastern Colorado. The network covers 16 counties. They are rural and frontier designated. It's about 30,000 square miles, about 170,000 people, more cattle than people. There are 16 hospitals. Most of them are critical access hospitals, very small. And you can see some of the other statistics, about 170 clinicians, and also home to 8 public health agencies, which I wanted to include because I know that your partnerships here with public health is very important. Here's another view of eastern Colorado that some of you might be familiar with if you've flown into Denver, or maybe you've zoomed through it on Interstate 76 or I-70. Here's another view of eastern Colorado, where our work occurs. And this region is home to many people who are passionate, creative, dedicated, and have a lot of pride in what they do in eastern Colorado. It's very ag-focused, a lot of farming and ranching, a lot of Friday night football. So these people include this group, the people I'm talking about, who are passionate about their communities. I want to start with describing the High Plains Research Network Community Advisory Council. We'll get to some of the other nuts and bolts in a minute, but they've been there's such a foundation of the work that we do, and again, I know that is what a lot of folks here are developing as well, our advisory councils. So this group actually was formed in 2003. It's been around almost 20 years. And the director who founded the network, Jack Westfall, said, I'm missing a voice. I'm connecting with clinicians and practices, but I want to know more what everyday people are experiencing. So he asked a group of about 10 people, no project in mind, just this concept of partnering with doing research and quality improvement in eastern Colorado. Come to the table, let's talk. They agreed. That was really the birth of the advisory council. The group is made up of about 10 to 12 people. They're farmers and teachers. They manage hardware stores. They are retirees. They have named themselves, we're free range humans. That's what they call themselves. A very grassroots group that is interested in this work, diverse backgrounds, and have come to the table for many, many years. All of them have that expertise of what it's like to live in eastern Colorado, to work, to raise a family, and to seek health care, and how folks communicate with each other. Their participation varies, meaning we all meet, but what they like to do in addition to our meetings varies, and we really like to take advantage of what people want to be doing, writing manuscripts. I'll get to that in a minute, actually, some of the other work that they do. But we know that groups come together for different reasons. Some research networks will have a specific project or a specific topic, and a group will coalesce around that, and which is wonderful. This group, this model, though, was more of a long-term partnership is what was in mind. And as you can see here over the years, they have participated in all aspects of the work. We do our best to talk with each other every few years, and we create what we call the top 10 list. I think right now there are about 13 topics on it though. But what is it that we're seeing in the data? What is it that you're living and experiencing that we should be focusing on? How do we prioritize what the funding is that we go after? They've done that. They've focused specific projects. They sit at the table and go over summary data and help interpret that. And they do a lot with dissemination. What do we need to do to get information back out locally, which is something I'd really like to talk more about today, as well as national conferences and even co-authoring papers. Okay, so I'm going to transition here and talk a little bit more about the nuts and bolts. This isn't nearly as colorful, but it's that important infrastructure and structure information. Like I said, we're based in the Department of Family Medicine. What does that bring to the table? We get really essential infrastructure support. We get access to grants and contracts management, admin assistance, space, all those things you need to function. We're a member of what's called the State Network of Colorado Ambulatory Partners, Practices and Partners, or SNOCAP. That is an umbrella entity, which I think here at the University of Minnesota, there's a similar concept of an umbrella overarching entity that cuts across the different research networks. So our department actually has 4 practice-based research networks in it. SNOCAP gives us, again, more of that support. We also get support to each other and access to other researchers and ideas and collaborations. We are part of the Colorado's CTSA, so it's the Colorado Clinical and Translational Sciences Institute Community Engagement Program. SNOCAP and specifically High Plains Research Network is a named partner. And that also brings advantages to our network. We get recognition. We do draw some funding for part of our staff through that. And again, access to just opportunities to collaborate. So the team, a little bit more about our structure. So the team has, the structure has morphed a little bit. We have historically have had a part-time director, and by that, it's been a clinician. So part of that person's time has often been clinical care or other things, so they are a part-time director. We have a full-time co-director, which has been myself for the past several years. We also have a coordinator, and then we have, who I mentioned before, 2, we call them our field team. They're 2 community research liaisons / practice facilitators. And we have 2 of them, and they each cover really broad regions. One covers a 9-county region, and the other a 7-county region, which is about 25 practices each. So a little bit different than how it looks here. And those asterisks before were indicating we're grant funded. So aside from the support from CCTSI, we're completely reliant on external funding. All right, so that's kind of how our shop is set up and who some of our initial partners are. But let's transition now and just talk about why practice-based research. I want to take the next few minutes to just feature a few projects. There are about 4 I've picked out to highlight that we've done over the years. We do this work because we want to improve the health of people in Eastern Colorado, very much like most people want to do. I want to just feature different projects that show different sizes and funding agencies and purposes. This first one was a project called Just Check It. Started as a pilot grant with funding from our CTSA. It is a practice-based intervention to implement home blood pressure management. Hypertension was one of the health issues that we heard from both our practices and our Community Advisory Council as being a big issue in Eastern Colorado. And the evidence really was supporting home blood pressure management. So what this included was training for practice teams, not just clinicians, but the full team in hypertension and home blood pressure management. We established a report system where patients and clinicians would get feedback on home blood pressure values. The Community Advisory Council developed a patient toolkit, as we called it, to give to patients who enrolled. And we also provided, through our research liaisons / practice facilitators, ongoing implementation support. So trying to have that presence in the practice beyond just that initial training. I'm not going to actually focus a whole lot on study results, but I do include some of these to show that, yes, we did see clinically and statistically significant changes. This also was a great partnership with the local public health departments. This was an opportunity to say, we're going to go train practices. You also have goals and relationships with the practices. How can we work together to help build a community that's working around this and to support what's happening in the local public health settings? Okay, this next project was called It Matters. I'm not going to bother with what It Matters stands for. And yes, there are 3 T's in there. We were talking earlier today about site visits to practices and hearing themes bubble up. I don't know what to do with my patients who keep coming in and wanting prescriptions, and I don't think they need it anymore. What can we do? There was a global theme. This was back in 2016, 17, about opioid use. We said, okay, we've got to see what opportunities there are. A funding opportunity came out from the Agency for Healthcare Research and Quality, specifically around training rural primary care in providing treatment for opioid use disorder with buprenorphine. And we said, no one specified treatment, but this is a way to start to address this. And we received this award. This was a multi-component randomized study, actually, where we provided training to practice teams. Again, not just the clinicians. The clinicians had their training they had to do at the time to get a waiver to prescribe buprenorphine, which is the medication used to treat opioid use disorder and dependence, I should say. We wanted to engage the whole practice team in this. That didn't exist. So we actually created a curriculum for primary care practice teams, 4 modules, to do this work. Our Community Advisory Council, way back when, said, what you are doing in the practices, it can't just stay within the walls of the practice. Now, this is something I really encourage this group to think about, and others on Zoom. If you're we're in a rural setting. In many communities, there's one practice in town. In most communities, there's only one practice in town. And you see your doc at the grocery store and the football game and wherever, the club. What does that look like in a more urban setting? Because our group said, we need to do things outside and generate conversations outside of the practice in order to support what you're doing inside the practice. So many projects have used this model where we had a complementary community-facing intervention that was designed to increase knowledge and awareness of opioids and opioid use, and that treatment can be received locally at your primary care practice. We really wanted to change the conversation around this, and that's the approach we took. Again, you can see we had 30 of the 50 practices in Eastern Colorado participate in this, and we had increased prescriptions for patients, and also this chart just shows that compared to the rest of the state, the rate of that increase was greater in that study period time. Okay, so this next project, very excited about this example. It's called the CAPTURE study. And again, doesn't matter what CAPTURE stands for, but there's a thing called the CAPTURE tool. And this is a 5-item questionnaire that was pilot tested by researchers at Cornell University. in a specialty clinic setting for patients with COPD. This was about how do we better identify patients who have COPD symptoms to accurately diagnose them and then refer them to treatment if they need it. COPD is huge in Eastern Colorado. So again, we were approached. This was a great example of a collaboration with other researchers, not just in the university, but around the country, to bring the rural experience to this study. This was involved several other practice-based research networks, as you can see, Duke, Atrium, which is in North Carolina, LA-NET in Los Angeles, our friends in Oregon, Chicago, and then there was the High Plains Research Network. We were really excited. They're just doing analysis now, so I don't have results. But I wanted to test then the ability for this new questionnaire plus peak flow to identify, accurately identify symptoms previously unrecognized. So an exciting study that could really change COPD care in primary care settings. What High Plains did, we enrolled over 600 patients. There were 5,000 total. And again, part of our passion is we want to give folks the opportunity to be included in the research that's happening around the country. In rural, remote regions, that's difficult. And it really, I was just tickled. One of our nurses, who's our nurse champion at one of our practices, said, "This, I think, was my favorite study." And I just thought, really? Of all of them over the years? But patients were saying, wow, I could do this. And even one of the other patients said, you know, my father had COPD. I really was excited to be a part of this, and I didn't have to drive to Denver. So thinking about how practice-based research is opening opportunities for folks who want to contribute as a participant even, and otherwise that would be really difficult. The last project we'll feature, this goes back a little ways. So I'm feeling kind of old these days when I look at these dates when these studies happened, and this is almost 10 years ago now, when the patient-centered medical home was kind of the new hot thing, and practices were being told, you need to implement all these elements, all these aspects of care, and it's going to impact your payment. And you know, a lot of our practices were saying, what do you mean a medical home? I'm already a medical home. I'm the only place in town. What do you mean a huddle with my nurse? I need to do that every day. We share an office. We talk all day long. Why are we being told we need to do this? And how do we capture what we're doing? So this is a lot of words. I want to feature, though, that this was a card study that we did. And some of you may have heard of a card study. It's a great way to collect a lot of data quickly around what's happening in a practice with very low burden. So really focusing on that last line, we did a card study where we wanted to ask clinicians for every patient they saw in a day, or for some it was half a day, so not long. Which of these elements of the patient-centered medical home did or do you think would have benefited that patient? Just to get a sense of what they were thinking about all of this. Very simple, for every patient. We had 78 clinicians from 37 practices. We had data collected on over 1,000 patient encounters. So again, and the results were very interesting, but I really want to focus on this process as a tool to use to engage practices in something that can be quick, low burden, but meaningful, and provide some actionable data. We wanted to use this actually, as you can see too, to maybe give policymakers some additional information about what they were asking practices to do. Okay, so those were just a few examples of some projects we've done, different funding agencies. That last one, I should say, we did with internal funding. So we were talking earlier just about kind of the challenges of practice research and practice-based research. Why do it? There's so many challenges. You have to get funding, constantly, funding. But practices are busy. We know they're busy. This is often not a priority. Some just aren't interested. We kind of say there's this constant working the soil, to use my Eastern Colorado analogy. Why do we do it? Some of you might know Morris Wood. He founded the North American Primary Care Research Group. Some of you might go to that annual meeting. Again, a pioneering clinician researcher. And I love this quote: "It's imperative to marry the intellectual rigor and perseverance with interpersonal kindness." And for me, practice-based research is a way to do that. It's about relationships. It's about long-term. This isn't, we're not about having one study going in and then leaving. And I feel like practice-based research allows that to happen. So how do we do that? How do we marry intellectual rigor with interpersonal kindness? I'm going to switch gears a little bit and talk about what we call the care and feeding of the network. There's a lot that goes on, that needs to go on outside of a specific project. And I know many of the folks sitting in front of me in this room are the key to that happening in your practice-based research networks. But I want to share what some of the strategies are that we've used. I have quite a list, so bear with me. And I think some of these many folks are doing, so maybe it'll just be validating to say, yeah, that is what we're doing. Partner with your patients and community members. Get that other's perspective. Do windshield time. For me, windshield time means driving hours and hours. For you, it might just mean a short drive or a walk even, but the point is to get out of our comfort zone, out of our office and into the practice, into the community. We take road trips, multi-day road trips to visit practices. We try to get out there a few times a year. Our local field team is there regularly and tries to do site visits every few months if they're not there more frequently for a project. Get some swag. swag, yeah. Whatever you think is needed or kind of creative. Mugs and pens are very common. I wanted to show one thing that we've done now for many years. It's just our HPRN desk calendar. We stole this idea from a vendor at a conference. What we do is we put out a call for photographs of rural Eastern Colorado to our practices and our community advisory council. We've been doing this now for 12 years. They then forward it to the folks they know. Hey, you need to submit a photo. We get photos. It's a calendar, but we also use it to share information. We share study results. We talk about new studies coming up. We say, hey, share your story. What are you doing well in your practice? You want to toot your horn? Let us know. It's a communication mechanism. And what's been so funny is sometimes the practices that are just so quiet for a while, we go to visit, and what do they have on their desk? They have their desk calendar. Oh, we love these. I mean, they're paying attention. It's a way to communicate. So think about just what those creative opportunities might be. Did I do that right? Am I going? Okay, so we've already discussed this a little bit through the examples I gave. Doing a mix of different study types, scope, and duration. We don't want all of our grants to be big, long, really intense experiences. What are some of those to do those, but also what are some of the quicker, low burden ones that you can do? Share study results. I know this sounds so fundamental, but it's so easy to not do this adequately. And I'll tell you, we continually are challenging ourselves to do this better. Get the information out to your practices, not just the clinicians, but the whole team, but also your patients and your broader community. Again, in the rural setting, we've done that by putting articles in the local newspapers. I was thinking maybe in a more urban setting, there might be like a neighborhood newspaper, or again, just thinking what's like that. Gone on the radio, we've given talks at clubs and organizations. What are some of those things you can do? Because I'll tell you, we've had patients say, I didn't know my doctor was doing that. I think that is so great. I love that my practice is a part of this. So it's just another way to energize people, get excited. Invite people to local and national conferences. Write that into your grants, write travel money and for your clinicians and staff or your advisory council members. Take them where we go. And then the last little tidbit here, we all try to provide some kind of resource, right? We have the wonderful crew that spends time in the practice. Is there money? Is there equipment? Is the project involved? We did a project where every practice got a spirometer for free and a printer. So things like that. Money is a little tricky, and I think particularly with systems, in this case here, it might look different, but I know with the systems we work with, it's really hard for the practice team to actually see those dollars. So I think it's still incredibly important, but how we distribute that, we're beginning to think a little differently about that. Talking more about our field team, we have taken the approach of training them not only in research. Their main thing is that relationship. They're the key to the back door to that practice, the relationships, the interpersonal communication, but then the research skills, but also training them in practice facilitation. And it has been a really successful model for us. And it just enhances the projects where there is that implementation component. And certainly when the funding ends from a particular study, like Just Check It is a great example, our field team is still there and can still go in and support the implementation and sustainability of some of these interventions. They also connect, what's so-and-so down the road doing? I have a question about this organization. You know, they kind of become the local connector, if you will. So really utilizing that team. And then, as you've seen, and I'm sure happens here, we're not the PI on every study we do. There's a lot of collaboration, and that's a great way to expand the research portfolio. All right, I gotta wrap up here. So what's happening right now in our network? What are some of the things we're thinking about? This is a question that's always been there. It's under my skin a little more lately, is how do we take some of these interventions that we've developed and really make them sustainable programs? And that, I think, involves a lot of collaboration and partnership development with other folks, like here on campus, others that are take that technology, if you will, and can develop it into something that is sustainable. But how do we do that? Policy implications. Big P policy. I don't know how many of you have relationships with a local legislator. Not every project is going to have that, but when it does, how are we feeding our study results, not just to the academic journals and our meetings, but our local policymakers? And then there's always the little p, which I think more in the practice setting. How do we, again, make some of these things really embedded in their care and systematic and a policy from that perspective? And then COVID-19, I just put that up there because we know there's so many implications from that and so many challenges that we're facing now with that, and no easy answer. So to wrap up, what else, in my opinion, does a successful practice-based research network need? You need food and coffee. And you need to find a way to pay for it. I really wish some of those federal funding agencies would change that policy about food. And it really does matter. Think outside the box. This is one of the Just Check It materials that our CAC thought of. They wanted to normalize checking your blood pressure at home. Just do it like you do your weather and your crops and your fence and your furnace and your cow herd. Be excited about your work. That'll wear off. It's contagious. This is some practice members who were really excited about the study they were working on. Obviously, we need to respect people's time, value their relationships, take it seriously. These guys You keep me on my toes. You gotta laugh, have some fun with what you're doing. If you can see that. And just remember, what you're doing matters. I put just a few select publications here if anybody's interested. I want to say thank you. This is just some of the group that has contributed to the iPlans Research Network over the years, certainly to the work I've been doing. And thank you.
All right, thank you, Linda. For
Yeah.
that, thank you, Linda, for that presentation. So let's see, we have about 20 minutes and we have time for questions. So managing the hybrid Zoom. One question from Genevieve. Love the idea of engaging public health to amplify the work as described with the Just Check It project.
Yeah.
How did High Plains approach this?
Yeah. So we had, the Just Check It program had actually started as just really focused in primary care. And the more we were talking about it, we were like, gosh, why are we not engaging more? Our relationships with the local primary care agencies, it's an area we constantly need to feed and frankly, pay more attention to. We had relationships with them. They knew about the work we were doing, but we weren't regularly communicating and really maximizing this. So when this funding opportunity came up, which was from the state health department, we thought, gosh, let's reach out and let's look at what they need to be doing and are planning to do, and see if this is a way we could capitalize on this. And so we would still have the practice-based elements, but we wanted to take it out of just there and say, where are all of you in your community to talk about the importance of hypertension, to let people know about this resource. So it really was a great way for them to become engaged in the project, make community members aware of this, enroll them, and then make sure they had a medical home. So the public health department was not doing the care, but they would identify patients, for example, at a health fair. Don't get me going on this. I've been steeped in, been kind of told how some of the weaknesses of health fairs where we identify a problem and then what do you do? So this was a way to say, hey, you actually could benefit from this program. Where's your medical home? If you don't have one, let us help you find one. So they would have that connection with their local primary care practice. So they really took this on. It was really fun to see some of the local public health agencies develop their own Just Check It materials. They made t-shirts, they just did all sorts of things that they could do. And then to see them also utilizing their relationships with the practices, those vary greatly across the 16 counties. But it was also a way for them to get in the door to the primary care practice and build and enhance their own relationships that they had. So we actually wanted, at the end of the day, to kind of step back and say, we support this reporting system and we want to support the program, but you guys take this, you take it, go with it. So does that answer your question? Yeah. It's a great example of a program that grew out of research, and now it could be a sustainable program if we can, again, think a little differently. It's a completely different way of thinking than research. It's how do we fund this? Who needs this to take it on? So,
Any additional questions in the room?
There's one on the chat.
Do that first.
It's the same one.
Oh, Do you want to ask your question? I'll let you ask your question first.
We're so used to just putting everything in chat, aren't we?
So my question is specifically about card studies and whether these days in the High Plains Research Network, whether those are happening digitally or if they're happening still on note cards.
Yeah. Well, they're happening more on paper, and I'll explain a little bit why. But it's a great question because it introduces the idea of how else could we do these. And in some settings, I think doing it digitally would be fantastic. And in my mind, I'm kind of going different directions how that could be done. In some cases, there could be a substantial expense. You know, maybe you buy iPads and you have that, or maybe they exist already, but how do we do that? This one, again, I will say, it's been a little while since we've done a card study. We are very due for a good card study in the High Plains Research Network. So this one, we did on paper. Our practices are not affiliated with the university. There's one practice in the whole region, that's the university. So we're working with independent practices, FQHCs, hospital-based clinics, all different EHRs, you know, just in some instances, the good old paper pen is the most painless way. There's a lot of work on our side to then enter that. But your point is really important. There are other ways these could be done, and I'm sure others are doing it. So it'd be great. Modernize it a little bit. Actually, can I say one more thing? There is, now that you say this, there is a new app that's been developed with the Robert Graham Center. So is that, you know about that?
I met Jack
Okay.
at the NAPTRAC conference.
Yes,
So,
yes.
I have the app.
There's a new app, and it's just fresh out, you know, hot off the press to do just what you were asking about. So, phew, glad I've mentioned that, so I won't get in trouble now. Yeah.
Other questions in the room?
How many of the initiatives that you've spread have started as sort of directly from the practice spread across, or
Yeah.
how does that tend to work?
Yeah.
Restate that question for the.
This is Genevieve. I asked about how the initiatives start, you know, whether it's, I don't know, something where there's interest at a grant level or an investigator, or does it come directly from one of the practices in Eastern Colorado? Yeah, that type of thing.
Yeah. So, like I mentioned, the top 10 list that we try to keep, that is informed and created by our Community Advisory Council, but also through our conversations with practices. I should have had a picture of that. I should have brought that. The categories, the topics, some of them are specific, but some are pretty general. That is really one of the main resources we use. But again, it's those, I'll say, more real-time conversations even that we have with practices. They often don't say, I'm interested in this, I want to do a research study on topic X. They'll say, COPD is a big problem in my practice. How can we do something around that? And it's general. And so when we have opportunities such as the capture study, we do have an informal medical advisory council, which I didn't mention because it's very informal. And we have intentionally kept it that way because we don't want folks to be like, oh, this is one more thing I need to do and I'm not going to do it, when it's very low maintenance. We'll often feed that opportunity and say, hey, what do we think of this? COPD is an issue. Here's an opportunity. You know, thumbs up, thumbs down. What do you say? So that is one guiding strategy we use. But we really do try to have everything bubble up from practices and community. Our directors have had their own interests. The founder was particularly interested in heart health and cardiovascular disease, but we didn't do a whole lot on that. The most recent director was really focused on diabetes, huge issue, very relevant. But again, the question would be, okay, within that scope, what will make sense here? So yeah, we really do try to do that. But yeah.
Yeah, so the separation of your health systems and like
Yeah.
clinics and hospitals from the university, would you say that makes like the
Would you say that makes the approval process and like your IRB reviews and your grant funding, would you say that's harder or easier since they are a little bit more removed from each other?
Yeah.
separate entities?
So we actually have, I'm trying to think here, within the network, we just have one system that has its own IRB. So there are about 4 practices that are impacted by that. And that is a little bit of a pain. The others are unaffiliated, well, the ones with the university, so they're already covered. So we actually have an agreement, an FWA, which federal something. I should know what that is. That then they're covered under our university IRB. So that makes it actually very easy. But the practices that have their own IRB, yeah, that's more time, more money, and yeah, we're working with them to try to streamline this process. Yeah. Good question, though. IRBs are always interesting and different, different settings.
Okay, any final question? Here or online? All right, I think that's it.
Great.
Thank you very much for
Thank
your
you.
talk today, and we'll look forward to seeing everyone on November 1st for a presentation by Dr. David Dorr.
Thank you.